Good evening, everyone. I'll be presenting the clinical profile, imaging, and the treatment outcomes of retinal vasculitis at a tertiary hospital in India. The aim of this study is to describe the clinical profile, FFA, SSOCTA findings, and the treatment response among patients with retinal vasculitis. It was a retrospective observational case study from 2016 to 24. All patients had optos imaging, FFA, and SSOCTA done with tailored lab investigations, following which the treatment was initiated. Coming to the results of our study, a total of 136 patients were analyzed, in which the majority of patients were found to be in the age group of 31 to 40 years. 81.6% of our patients were male. The most common presenting complaint was diminution of vision, which was accounted for among the 64.7% of patients, followed by floaters in 14.7%, and the disease was bilateral in 53.6% of patients. The most prevalent presenting complication was vitreous hemorrhage, which was noted in 19% of the patients, followed by retinal vein occlusion in 8.1%. The most striking fundus fluorescein angiogram finding was peripheral vascular leaks seen in 23.5% of the patients, followed by neovascularization elsewhere with capillary non-perfusion in 21.3%. Capillary ferning was seen in 15 patients, which accounted for 11%, and most of these patients were found to have Behçet's disease. The most prevalent SSOCTA finding in our study was epiretinal membrane, which was seen in up to 68.3% of the patients, followed by ellipsoid zone defects in 39.7%, RP bumps, which was seen in 22%, cystoid macular edema in 11%, and neovascularization in 4%. The most prevalent etiology was TB retinal vasculitis, which was seen in 71.3% of our patients, followed by Behçet's retinal vasculitis in 13%. The other causes were SLE retinal vasculitis and sarcoid vasculitis. Now, coming to the treatment, systemic steroids form the mainstay of treatment in our patients. Immunosuppressive agents were used in 50 patients, out of which mycophenolate mofetil was the most prevalent agent, and biologics were used in 10 patients, in which adalimumab was the most prevalent agent. Seen on the right is a patient with TB retinal vasculitis, which improved remarkably after treatment with ATT and steroids. Retinal lasers and surgery were also done where indicated. Seen at the bottom is a patient with Behçet's uveitis, which showed a remarkable improvement after treatment with adalimumab. The ultimate visual outcome post-treatment showed an improvement in 31.6% of the patients, and the vision was maintained in 52% but worsened in 12.5%. Comparing this study with a similar study at a tertiary eye care center in eastern India, the demographic data was similar. However, the macular abnormalities noted in that study was far fewer compared to ours, and immunomodulatory treatment was only used in seven patients in that study, in which azathioprine was most commonly used and MMF was not. Immunosuppressives in our study were used in 36.7% of the cases, out of which MMF was most common. Lin et al. Have concluded that aggressive IMT is preferred to achieve a steroid-free durable remission for non-infectious occlusive retinal vasculitis. Optic nerve atrophy, macular ischemia, and a poor BCVA at the initial visit predict a poor visual outcome. Biologics were used in 7.3% of our cases, where adalimumab was most common drug. Retinal surgery was indicated in those with persistent vitreous hemorrhage and retinal detachment. Nagaraj et al. Have shown that the overall anatomic success rate of retina reattachment surgery in patients with retinal vasculitis is quite good with timely intervention. To conclude, retinal vasculitis may be the initial manifestation of several systemic diseases and is often a diagnostic challenge. It is essential to suspect these etiologies and perform specific investigations that helps to diagnose them early and prevent dangerous complications. Thank you.
Thank you. In this 36% of the cases you have used immunosuppressive therapy. In that you have chosen MMF as the first drug. Any specific reason?
No reason, ma'am. Ma'am, all the patients were seen by single physician, consultant, Dr. J. Biswas. So, sir prefers to use MMF first in most of his cases. So,
Maybe because
And in
big
your
chunk of them are Bessett's also.
in TB, I mean, also sir has used my MMF first.
And in the commonest was the TB. In TB, retinal vasculitis, did you see any specific pattern, like scar along the vessels? Those kind of a thing was seen in how many percentage of patients?
No specific pattern, ma'am. It was
Especially when we put it like, you have a TB specific pattern, like for example, sarcoid, you'll have a Candleback's
Candleback's, yes.
and SLE, you will have multiple cortical spots with vasculopathy. So the typical ones for how many and the atypical how many, that will help you to characterize them morphologically in addition to the etiological one to correlate with the imaging biomarker.
Okay.
So how did you come to the diagnosis of TB vasculitis?
Ma'am, based on the laboratory investigation, MAN2, QTB, HRCT chest, and the clinical features, if they were eels-like manifestation clinically.
I'll just ask if the next speaker is there. Can I just have one speaker?
Thank you, Dr. Namitha.
Thank you.
Thank you.